Perfect. We are live. Good morning, everybody. Just going to give everyone a couple more minutes to get signed on here and situated before we start. So if you just want to hang out and then we'll get started here soon. Good morning, everybody. We'll get started here. So I want to welcome Dr. Veronica Bruno from the University of Calgary. She's going to be presenting to us on PD and the botulinum toxins. And my name's Brianne Leclerc, and I'm the Client Service Coordinator down in Lethbridge and Medicine Hat. So thank you for coming out to our webinar today. And that if you have any questions during the webinar, please just submit them in the chat below. And that's at the bottom of your screen there. There's a little chat icon. Click it and the chat will appear on the right-hand side. You can send your questions out to the whole group or just the panelists with the drop-down arrow. And then we'll ask the questions at the end there, but you can type them in through the chat whenever. A quick disclaimer, this webinar will be recorded. All information provided is in the videos by Parkinson's Association, and the featured speaker is furnished strictly for educational and entertainment purposes only. The service is not intended to be diagnostic, prescriptive, or replace the relationship, advice, and or care of your physician. General questions about symptoms, treatments, available medications, complementary and alternative healthcare therapies, and current research will be fielded. All right, so I will turn it over here. And that to you.
Hello, can you hear me? Is it working? Good. Okay, well, thank you everybody for being there. Thank you for Parkinson's Association of Alberta for inviting me to talk to you today about one of my favorite topics. This talk will be mostly a conversation about botulinum toxin uses in Parkinson's disease and also in other Parkinsonian syndromes. It's a very specific topic, but I hope that you find it helpful. And if at any point in the future you find that you could be a candidate for one of these treatments, you have enough information to talk to your neurologist about it. So I'm one of the neurologists here in Calgary. I have been here for almost 3 years. So some of you may know me, some of you may not know me at all. After this webinar, I will be happy to talk to you about any thing in the future and also interact with you in clinical or research settings. So as a disclosure, before starting my talk, the use of botulinum toxins has been part of my research. So I have received some research support from 2 of the companies that produce the toxin that are available in Canada. In terms of what are we going to talk about today, I would like to touch base on some of the potential questions that you may have about the use of botulinum toxin. First, let's try to define what botulinum toxin is, which symptoms of Parkinson's disease can be treated with the toxin, what are the potential side effects of these treatments, and then we will briefly go through some special considerations. During the course of these slides, you will see that sometimes I write PD instead of Parkinson's disease to make it shorter, and instead of the full botulinum toxin words, I will use the abbreviation BONT. So let's start from the very basics, trying to describe and make clear what botulinum toxin is. And botulinum toxin is the right name to use because the other names that are more famous are just brands. So there is a bacteria that is called Clostridium botulinum that produces this very extremely potent neurotoxin, the most potent neurotoxin known, that is called botulinum toxin. The bacteria itself produces an amount and a type of toxin that is extremely dangerous and causes a disease called botulism. And probably you heard of botulism, but botulism is basically characterized by paralysis of all the muscles in the body. It's an extremely life-threatening condition and requires a very strong supportive treatment that sometimes is not successful. It's not a fun thing to have, but the good part about Clostridium botulinum is that researchers through the years learned that we could extract that toxin and use it to paralyze muscles in a very targeted and safe way. So once that we have extracted that toxin, how does it work or what does it do? And basically, in scientific terms, what the toxin does is to inhibit the release of acetylcholine, that is a neurotransmitter, in what we call the neuromuscular junction, blocking the neuromuscular conduction. So in more basic terms, if in the drawing by my right, you can see there is a blue and a red structure. The blue represents the nerve and the red represents the muscle. The nerves have to send information to the muscle to make it contract. What the toxin does is to inhibit that communication in between the nerve and the muscle, so the muscle doesn't contract and becomes weak or paralyzed. Since the uses of the toxin have been discovered many years ago, it has been widely used for different purposes. In fact, the first time that the toxin was used for medical purposes was many years ago in 1977 and was used mostly for the treatment of strabismus. Now the toxin is very famous, mostly because it's used for cosmetic reasons, like making wrinkles disappear. If you think about how it works, because it makes the muscles weaker, the expression muscles weaker, the wrinkles will not show as strong as if the muscle was contracting with all the strength. However, the cosmetic use is not the most important one nowadays, and the toxin is known to help many health conditions. And in fact, it is approved for its use in, for example, patients with chronic migraines that do not respond to any other treatments, Patients that, for example, had a stroke or were born with cerebral palsy and have severe spasticity. Patients that have neck torticollis, or what we call cervical dystonia. Patients that, for some reason, develop a spasm in one side of the face that is very hard to treat. Patients that have symptoms in the bladder compatible with overreactivity. Patients that clench their teeth a lot with GMJ disorders. And also for other disorders such as excessive saliva or excessive sweating that we will discuss next. The toxin can have different serotypes, 7 in total, but of those, only 2 are available for medical use, type A and type B. In fact, in Canada particularly, there are 3 products approved for therapeutic use, and the 3 of them are toxins type A. You probably heard of them because the names are mostly famous. They are Botox, Dysport, and Xeomin. And they have been approved for different uses. In the United States, but not in Canada, there is a type B botulinum toxin approved that is called MyoBlock. Around the world, there are many others brands of toxin. What is most important for you to know is that each one of these products has unique characteristics. They have different molecular weights. They are associated with different proteins. Their onset of action may be different. And also the diffusing properties are different. This means when we inject the toxin, sometimes it spreads to other areas in the body. So it's important for you to know that you have received treatment with one of the toxins and then you're going to switch to another toxin. The agents are not therapeutically interchangeable and you need to talk to your doctor about it because some modifications in the treatment may be needed. So now that we know that basically the botulinum toxin is a very potent, I like to call it very potent local muscle relaxant because it just works where we inject it. I would like to help you go through what Parkinson's symptoms could be treated with the toxin. What are we doing right now? What we may be doing in the future. So for patients with Parkinson's disease particularly, most of the symptoms, such as the tremor or the slowness or the stiffness, can generally improve with oral medications, basically with a treatment with levodopa or with other medications that we use to supplement the use of levodopa or with deep brain stimulation. However, there are many other symptoms of the disease that are not responsive to the classic treatments that we use in clinical practice. This is also true for the patients that do not have Parkinson's disease, but have what we call an atypical Parkinsonian syndrome, such as progressive supranuclear palsy, multiple system atrophy, or corticobasal syndrome. For those patients, unfortunately today, we don't have any strong oral agents to treat most of their symptoms. So based on the lack of oral treatments to improve some of the symptoms, the use of botulinum toxin has been tried to treat a variety of different symptoms of the disease. I will divide the symptoms that could be treated with botulinum toxin in those that involve movement, what we call motor symptoms of the disease, and those that do not involve movements, that are what we call non-motor symptoms of the disease. In terms of motor symptoms of the disease that could be treated with the toxin, we will be touching base on limb dystonia, hand and jaw tremors, blepharospasm and lead apraxia, and I will describe what all this means soon, and some postural disorders. What all these symptoms share as a characteristic is that there is an excessive muscle contraction. So if you think about it, it makes totally sense to use an agent that is a local muscle relaxant. In terms of the non-motor symptoms that could be helped, we are going to speak about salorrhea, that means basically drooling or excessive saliva, overactive bladder, and some other symptoms that could or could not be helped by the toxin, such as some of the swallowing problems, some of the very severe constipation cases, and excessive sweating or hyperhidrosis. By the end of the talk, I will just quickly mention some of my main interests in the research that is related with the use of botulinum toxins for some types of pain in Parkinson's disease. So when you think about these disorders that I just mentioned, the saliva, the bladder, the constipation, why would they be helped by a muscle relaxant? So the truth is that the organs involved in these problems, such as the bladder or the salivary glands, have a very small type of muscle that is called smooth muscle that is controlled by what we call the autonomic nervous system. Unfortunately, that muscle also responds to the inhibition with the botulinum toxin. Going more in detail, now we will talk firstly about what are the Parkinson's disease motor symptoms. So as I mentioned before, those related with movements that could be helped by the treatment with botulinum toxin. So the first of them is what we call limb dystonia. You may or may have not heard about this concept, so I will describe it a little bit. So dystonia has a very specific definition. It's a movement disorder characterized by a sustained or intermittent contraction of the muscles that can produce a twist, can produce a repetitive movement such as tremor, or can produce an abnormal posture. Dystonia is a condition or a diagnosis per se. It's not only associated with Parkinson's disease, but an average 30% of patients with Parkinson's will present dystonia at some point, and this is even much more common in patients that start having symptoms when they are younger than 40. More commonly, we see dystonia as part of a motor complication of the levodopa therapy in the spectrum of dyskinesia, or as an off phenomenon. You know, we call off phenomenons those symptoms that appear when you are not receiving therapy with levodopa. For example, first thing in the morning when you wake up and you didn't take levodopa through the night and you experience some strange things. So those symptoms, those off symptoms, one of them that is very common is the presence of food dystonia. And patients describe food dystonia in different ways. One of the most common ways is mentioning that they have cramps or curling of the toes. Sometimes it's all the toes curling, or sometimes it's the little toes curling and the big toe going up in a very painful way. Associated with the movement of the toes, sometimes the ankle also twists, sometimes like in an inner twist, sometimes in an out. Depending on the pattern of dystonia that patients report, that's how we select the muscles that we are going to inject. So just to give you some examples based on the muscles of the foot, if you had strong curling of the toes, we may have to use injections in the plant of your foot, where most of the muscles that flex your toes are. If your big toe goes up, we may need to inject this muscle here that basically extends the big toe. If your foot does this movement coming inside, we may inject this muscle here that is called tibialis posterior. That is the one that is mostly in charge of that movement. So going directly to the muscle that is producing the movement via sustained contraction gives us the possibility of injecting only that one, avoiding side effects, and reducing the contractions, so reducing the symptoms associated with the dystonia. Some patients with Parkinson's, but not many, mostly patients with atypical Parkinsonian symptoms, may also develop dystonia in the hands. It's uncommon and rare, but it could happen that all the fingers and even the wrist can get this flex position that is very painful, makes it impossible for patients to use their hands in a functional way, and also sometimes makes the palm hygiene very complex and predisposes to hurting the palm and having infections. So when patients have those type of symptoms, we can also help with the use of the botulinum toxin. In this case, we will target the muscles in the forearm, as you can see in the drawing, that are related with the flexion of the fingers and the flexion of the wrist. This is usually a very low dose of toxin, and what we do, or we aim to do, is to help the fingers relax so that they are not all the time closed on the palm, helping the functionality, but also helping the pain and the rest of the symptoms that could be associated with this type of dystonia. Jumping into the second motor symptom that could be helped by the use of botulinum toxin, we will talk about tremor. And this, I don't have to tell you because you know it very well. Tremor in the upper and lower extremities is one of the cardinal features of Parkinson's disease. Patients can also have tremors affecting the chin and the jaw. And even if we optimize the treatment with the medications that are available, tremor remains sometimes difficult to treat, even when we have tried every single combination. For many years, researchers have been trying to use botulinum toxin to treat tremor in Parkinson's, but unfortunately, all the results were negative because of side effects. This means that patients reported so much weakness in the hands after the injections that they were not willing to continue with the treatment. Then, what became clear was that all those studies were targeting always the same groups of muscles and using always the same standardized dose. That's something that researchers do usually in order to avoid variability in the results. However, we know that for Parkinson's, it doesn't work that way. And if we are going to use botulinum toxins for the treatment of tremor, we need to select the muscles in a very personalized way, as your tremor may not be the same that other patients' tremor. And also we need to start at a low dose and increase it slowly. Moreover, now we have good things like good technology to help us target the muscles that make it more precise and specific. So for example, in our center, and I'm sure in many other centers, we can use electromyogram, that is a way of targeting the muscles and learning which are the affected muscles while we're performing the injections, and also using ultrasound in order to be able to see the structures that we are injecting while we are putting the needle in. So all those make the results of the new studies for the treatment of tremor with botulinum toxin much more successful. So again, if you want to know where we are going to inject you, if you receive treatment with botulinum toxin for tremor, it depends on the localization and characteristics of the tremor. For tremors that are mostly what we call flexoextension, we will inject the muscles in the front and the back of your forearm. Sometimes the tremors have also a little bit of a rotational component, and we need to inject some additional muscles in the forearm too. For patients that have tremors affecting mostly the jaw, we will affect what we call the muscles of mastication, of those that help you chew. Basically, the masseters, that are the muscles by the side of the head. Most of these injections are extremely safe, and the pain is just associated with the use of a very small needle. There is a third motor symptom that we can help with the use of botulinum toxin in Parkinson's disease, but mostly in atypical Parkinsonian syndromes. These two disorders that affect the muscles around the eyes are not so common in Parkinson's, but may happen in advanced stages of the disease or commonly after deep brain stimulation. They are extremely common in some of the atypical Parkinsonian symptoms such as PSP. Basically, they have very strange names. The first one is called blepharospasm, and it's basically an excessive contraction of the muscles in your eyelids that leads to excessive blinking sometimes. And when it's severe, it can produce completely eye closure, and it generates a lot of discomfort. And of course, you cannot, for example, you cannot drive if your eyes are closing all the time. The second one that sometimes comes in association with blepharospasm, but sometimes it can occur independently, is what we call apraxia of eyelid opening. And in this case, the problem is not a continuous contraction, but it's an inhibition of the contraction of the muscles that will open your eye. So patients try to open the eyes, but they cannot. For both conditions, we can use botulinum toxin with very good results. So the muscle that we would target in the cases of blepharospasm of apraxia of eyelid opening is this big muscle that is around your eye that is called orbicularis oculi. And basically it depends if you have been mostly the blepharospasm or the apraxia of eyelid opening manifestations, we will target which part of the muscle is going to be injected. I know that it looks a little bit weird to put a needle close to your eyes to treat a symptom, but I can tell you that we use such a small needle that most of the patients don't even notice, or just feel like a little punch, not more than that. And there are no significant side effects if they are performed by someone with experience, and the effects are very good in order to improve these symptoms, particularly the ones of the blepharospasm that, as I mentioned, can be kind of dangerous if you cannot open your eyes spontaneously. Finally, there is a fourth category of motor symptoms of Parkinson's and atypical Parkinsonian syndromes that could be treated with Botox. However, the evidence for the treatment of these is a little bit more controversial. Postural disorders are a group of disorders that can affect patients with Parkinsonism. There are different names that are kind of difficult, so I will mention, but you don't really need to remember those. There are patients that have flexion of the neck forward, like the figure number B here. That's something that we call antecollis or anterocollis. There are patients that can suffer flexion of the full trunk. That's what the figure A is showing. That is called camptocornea. And there are patients that can have a flexure of the trunk to the side instead of forward, and thinking of the Pisa tower, that's called Pisa syndrome. Those syndromes sometimes can be treated by modifying your medication schedule, but if you have tried everything and you still suffer in this, botulinum toxin treatment could be tried by experienced professionals. The muscles that we would target in this case depend on the characteristics of the postural disorder. For example, if you have mostly a flexion of your neck, we may target some muscles in your neck. If you have the flexion of the full trunk, we may target the muscles in your belly, because those abdominal muscles are the ones that seem to be contracting as part of the explanation for this disorder. And if you have mostly the contraction of the muscles in the back or in your spine that produce a twist to the side, we may inject what we call paraspinal muscles that are the ones shown in the figure on the right. Again, the evidence for the treatment of postural disorders is a little bit weaker than the one for the other disorders that I mentioned. Most of the literature that is available is based on case reports. Based on my experience, I can tell you that some patients can respond very well and some patients do not respond at all. So it's a very personalized decision, but it may be worth trying if one of these disorders is affecting your quality of life. Moving into the non-motor symptoms that can be held by botulinum toxin, we will talk again about those that are not related with movements, but can have a significant impact in quality of life. So the first one that we will mention is sialorrhea, or excessive saliva. Excessive saliva or drooling is seen in up to 80% of the patients with Parkinson's in advanced stages. This is not very common in the beginning of the disease, but when the disease advances, it becomes more prominent. The reason is not that the patients produce more saliva, but maybe the same amount of saliva that you were producing before now is harder to swallow because the reflexes are slightly reduced. So it tends to stay in the mouth and come out in the form of drooling. This is also not only uncomfortable, and patients don't like it, of course, but also increases some important risks, like the risk of aspiration or the risk of infection, particularly what we call aspiration pneumonia. That is something that for sure we want to avoid. There are some medications, some tablets that, or drops that you can use to try to treat excessive saliva in Parkinson's and Parkinsonisms. However, the medications are not extremely useful, and those that seem to really reduce the amount of saliva have side effects that are not something that we want to go through, to pursue. Mostly they generate a lot of confusion, hallucinations, or cognitive impairment. So of course, if we have to balance risk and benefit, we may decide not to use those medications. So trying to find alternatives for the treatment of this symptom, botulinum toxins were tried multiple times in very well-designed research studies. And every time that the different toxins were tried, the treatment showed to be safe and efficacious. The only side effects that patients can have after the treatment is dry mouth. However, for patients that had excessive saliva, this is rarely problematic. So where we will inject botulinum toxin if your problem is excessive saliva? Basically, we have 3 glands that are related with the production of saliva. The biggest one, that is the parotid gland, the submandibular gland, and the sublingual gland. The easiest to reach with needles is the parotid gland. We can, if there is no an optimum response injecting just the parotid gland, usually we try to add an injection in the submandibular gland. Again, this looks a little bit impressive, but it's done by experienced professionals with a very small needle, and usually it takes less than 2 minutes. The second non-motor symptom that can be treated with toxin is a very important one for everyone, and it's the presence of urinary dysfunction. As you know, genitourinary symptoms are frequent in all these disorders. Patients report that they have to pee a lot, particularly at night, or they have to run to the toilet many times during the day, and sometimes that can come with a sensation of urgency and incontinence. We have medications that we can try first, and that's what we would all probably do first. But if the medications don't seem to help, botulinum toxin is approved for the treatment of what we call neurogenic or overactive bladder. This is not done by a neurologist. This has to be performed by an experienced urologist who will use a special technique to inject the muscles of the bladder. The potential side effects regarding the treatment of urinary overactive bladder are related with maybe urinary retention if the dose is too high maybe, or infection. But to be honest, the risks are extremely low. So where I'm going to get those injections? So what the urologist does is use a technique called cystoscopy to introduce the needle through your urethra. It sounds impressive, but it's very simple. And we'll inject this muscle around your bladder that is called the trusor. That is the one that is contracting all the time, making you have the feeling that you have to pee all the time, that increased frequency and urgency. The good thing about the treatment with botulinum toxin for bladder issues is that it seems to last longer than the treatment in any other muscles. So most of my patients that are receiving this treatment are receiving it in a twice a year basis with very good results. Now I will briefly mention other potential uses of the toxin in Parkinson's disease. And I put this yes/no picture here because the evidence that we have to use botulinum toxin in these disorders is controversial. There maybe have been 1 or 2 studies showing some good effect, and a few studies showing no effect or significant side effects. When you read about it, you need to clearly consider what the case of the patients that were treated, because they may have completely different symptoms than the ones that you're presenting. So one of the symptoms that has been proposed to be helped by botulinum toxin is the presence of dyskinesia. I really don't need to describe what dyskinesia are. These extreme hyperkinetic movements that appear sometimes when the levodopa is at its peak, that can produce significant discomfort. In some of those cases, botulinum toxin could be helpful, but this is a very individualized decision and will depend on where the movement is, which structures it is affecting. Also, we don't want to make your muscles weak, because whenever these kinesias disappear, the effect of the botulinum toxin will stay there and you may not be able to use your limbs appropriately. So for these kinesias, there is little evidence and you need to talk to your doctor about the possibility, but I would say it's not the rule for us to decide to use botulinum toxin as a treatment. There were some studies a few years ago that mentioned that patients that suffer freezing of gait could benefit from injections with botulinum toxin in the calves. This study, unfortunately, could not be reproduced. The results could never be reproduced by other studies. So this is not a treatment that we currently use or try. Also because from a physiopathological perspective, doesn't make a lot of sense. And then there are some symptoms that are very specific and individualized, personalized for every single patient. For example, some patients that have grimacing as part of the dyskinesia or develop a dystonia in the jaw, clench their teeth when the medication does not or does kick in. Those patients could also benefit from injections in the muscles that I show for jaw tremor. In terms of non-motor symptoms, other cases that have been attempted to be improved by the use of botulinum toxin are, for example, patients that develop a particular form of a swallowing problem where the esophagus, that is part of the digestive system, moves too much. Or, for example, injections in the rectum for patients that have very severe constipation. Again, there are 2 or 3 cases published, some with positive results, some with negative results. So the possibility of using those treatments of the botulinum toxin in those cases, it depends on your particular case and the experience of your neurologist. Finally, there is an indication that is used in general population, that is the presence of hyperhidrosis. Basically, this means a lot of sweating, and the injections are performed in the armpit. And these can be done also for patients with Parkinson's disease or atypical Parkinsonian syndromes that may be dealing with this problem. Again, by the end of the discussion, I will show you some of our own data based on the use of botulinum toxin for pain in Parkinson's. So you heard that we can use botulinum toxin in different symptoms of the disease. Many of them are extremely common. So why don't we use it all the time in every single patient? And the truth is that there's different considerations. The first one is related with the potential side effects or issues that may be related with the use of botulinum toxin. What I always mention to my patients is that the good and the bad thing about the use of botulinum toxin is that the effects are transient. So it's good because if we have a side effect or we produce a side effect, this will not last, will not be permanent. The bad part is because the effect is not sustained. We usually need to repeat the injections every 3 to 4 months. One of the potential side effects, if, for example, we target muscles in the forearm or in the foot, is that we could produce an intentional weakness. However, this depends a lot on the location of the injections and the dose that we are using. So if we are sure that we are targeting the right muscles, that are muscles that are suffering increased muscle contraction, and we use a low to moderate dose in the beginning, this should be a side effect that could be avoided. Again, if it happens, that after receiving, for example, injections for tremor, your hand or your wrist is a little bit weak, or you have trouble extending your fingers. That would not last. As it wears, it can last a few weeks, but then the effect will wear off, as well as the side effects. Some patients, for example, patients that have some blood conditions or take blood thinners, may have a bruising at the site of the injection. The needles that we use, again, are so small that this usually doesn't happen. But it could happen that when we put the needle inside the skin, we touch a small blood vessel and there is a little bruise, usually with no major complications. In the past, and in hands that are not fully experienced, the third complication could arise. That is the spread of the toxin to distant locations. For example, injecting a high dose in the muscles of around the eyes, and because they're very small muscles, that could go to other parts of the face and make your face weak. And that's not something that you want to experience. However, using low doses, and again, in experienced hands, that shouldn't be a problem. And the good part, again, is that the effects are transient. So if it happens once, your doctor will know the next time the injections need to be performed in a different location or at a different dose to avoid that side effect, and that will not happen again. Finally, it's not a side effect, but it's an issue that we face because of all the indications, or most of the indications of the use of botulinum toxin in Parkinson's disease are what we call off-label, and there is not a strong body of evidence supporting their use. Many of the health insurers would not cover the treatment, and it can be pretty expensive. There are strategies to deal with this problem that you can discuss with your family, with your neurologist, but I would say that in most of the cases, this can be solved, at least in Alberta, but in many other places around the world, this treatment is not available because of the cost. There are some very important considerations, some very practical that you may want to know, and some very specific. And this is going to be one of the last parts of my talk. So some good things about the toxin. Let's speak about the positive sides. It's a clinic or office procedure. So you come for an appointment, you get your injections, then you go home. There's no anesthesia needed. It takes minutes, and there's no need to have any special care after that. So when patients leave my office, I just tell them normal life. You can forget about the injections. It depends on the location and the size of the muscle and the patient itself, how long it would take to start working. Some patients report that the effect starts pretty soon after the injection. Some other patients feel that they need at least 10 days to start noticing an effect. And it usually peaks, or what we call has the best of the effect, after 6 weeks, when the patients notice, oh, really, right now I can see that this is working. And after 2 months and a half, 3 months, the effect starts wearing off. And it's usually then when we have to reschedule another appointment in order to repeat the injections. Negative part, as I mentioned, that is that if you have a side effect, it may last days or weeks, but they are always transient. They would not be permanent. And then another issue that is, like, if I compare many of my patients that receive exactly the same treatment, the responses may be completely different. It's very personalized. So it makes very important for you to have someone with experience performing this treatment. In terms of some special considerations, again, my recommendation would be, if you try any of these for the symptoms that we discussed, try to do it with someone that had experience doing this before. If possible, go to one of the specialized centers that can use electromyogram or ultrasound guidance, because this helps to improve the targets, reduces side effects, and improves efficacy. If you have the brain stimulation and they're going to use EMG or electromyogram to target your muscles, you may need to turn the stimulator off for a few minutes, just because the signal of the stimulator may interfere with the signal of the electromyogram machine, giving some incorrect information. it's just a few minutes and it's usually tolerated by patients. As soon as the injections are done, we turn the stimulator on again without problems. And then you may have heard that there is a chance of producing antibodies against the toxin. And this makes sense. We are injecting something into the body that is in the not appropriate settings, may be recognized as something wrong, as a toxin. So your body may want to defend you from the toxin. However, this has changed a lot through the years. In the beginning, we had to use very big molecules. The molecules are becoming smaller and smaller. This reduces the chances of producing an immunologic reaction. If there is a reaction, if you produce antibodies against the toxin, they will not hurt you. You will not have side effects, but the toxin may stop working. So at that point, you may need to change toxins in terms of from type A to type B. That is something that is done, for example, in the US, but we don't have that possibility here because we don't have type B, or you have to stop receiving the treatment. However, as I mentioned, this is a very uncommon thing right now because of the improvements in the size of the molecules. So if you start to notice that the treatment is unsuccessful, before thinking that you probably have antibodies against the toxin, discuss with your neurologist about the possibility of changing the muscle selection or confirming that you are receiving the injections in the right muscles, and also maybe discussing the possibility of an increase in the dose. In a few more slides, I will quickly mention some research in the field that we're performing here in Alberta. And in fact, it didn't start in Alberta. I know that you know Dr. Miyazaki in Edmonton very well. She was my mentor when we both were working in Ontario. And at that time, we went through all the charts of patients with Parkinson's or atypical Parkinsonian syndromes that had received botulinum toxin for any of the reasons that I just mentioned. And there are a few. I don't want you to read this long table. I just will mention the most important findings. The most important findings is there were many patients with Parkinson's and atypical Parkinsonian syndromes receiving botulinum toxin for the different indications. And most of them reported good benefit, like a consistent benefit through the years. And the other shocking part for us was that when we look at what was the main indication in the population for the use of botulinum toxin, we found that it was pain. Pain can be, we will talk about pain in a month or so, but pain can be associated with different situations and conditions in Parkinson's, but it was interesting for us, so we decided to look a little bit more in detail, and we performed a little trial with 12 patients with Parkinson's and pain, and we found that those patients that have dystonic pain, that one that I mentioned in the beginning, the one that can produce curling of your toes or your big toe going up or inversion of the foot, that responded very well to the treatment. So now here in Calgary, we are performing this study to try the toxin for patients that particularly have that type of pain. So I will not talk a lot about this. If you, we're just starting recruiting patients. So if you are interested in receiving more information, you can contact my research assistants in this email or this phone number, and she will be happy to provide more information. So thank you very much for your attention, and I hope this was useful. I will be more than happy to hear your questions and try to provide an answer.
So we do have one question here right now. We'll probably get a few more roll in. So someone asked, is there a limit on how many Botox injections that you can get in a lifetime?
That's an excellent question. Thank you, Nancy. No, there is no limit in the lifetime. There is a limit in terms of the units that you can receive in every treatment cycle. So usually, for example, for patients with severe spasticity that receive injections in the upper and lower limb, the maximum dose that is attempted is 400 in total to 500. This is of the botulinum toxins type A with the Botox or Xeomin brands. The problem is that higher doses were never tried, and we don't know what the side effects may be. So For Parkinson's and for the indications that we just discussed, usually the dose is much lower than that, so there's no particular problem. The other limitation is how often you get your injections. For example, the ideal would be to wait at least 12 weeks. This is to try to reduce the continuous exposure of the body to the toxin, so we minimize the possibility of the body responding, producing antibodies or defenses. That's more relative now. Some people are performing injections even every 8 weeks, but those are the two main limitations: the amount in each cycle and the period, the interval in between cycles. But in the lifetime, there shouldn't be an accumulative effect, and there shouldn't be a limitation. There are patients with other conditions that receive this since they are children until they are in their 90s. So no clear limitation in terms of life. So I can see Robert's question. So explain the symptoms in terms of dysphagia. I don't know if you mean in general or for the treatment, the ones that were treated with the toxin. Robert, can you help me clarify that? So dysphagia means swallowing problems. Basically, that's the word that we use to describe swallowing problems. And they're not very common in Parkinson's in the beginning, but they can occur as the disease progresses. And it's basically patients that notice that when they're taking the pills, they may get stuck in the throat and they need more water, or that, for example, when they're drinking water or eating, sometimes they tend to choke. This is not, again, common in Parkinson's for many years. It may happen in later stages of the disease. However, it's much more common in patients with other disorders. So we really need to pay attention to those, basically because those are the ones that put you at risk of having an aspiration of food to your lungs and having a pneumonia, and that's something that we really want to avoid. So that's what we mean when we speak about dysphagia. It's the swallowing issues, like feeling that the pills or the food get stuck in the throat and we need some additional efforts. And we have a great team of people here that can assess that and can give you some advice if that is happening. In terms of the botulinum toxin, that's why I put it in the controversial part, because those may not at all help with Botox or with botulinum toxin, but they may, there's one specific type of dysphagia that may be help, and it's not very common. So I don't want you to keep that in mind as an indication.
Then I have a question that was from one of the clients down here. They were wondering if people with dementia related to their Parkinson's or dementia in general that have Parkinson's as well can get Botox therapy done.
Yeah, absolutely. In fact, some of these problems may happen in very advanced stages of the disease where dementia is maybe part of the picture. So if that happens, there's no contraindication at all. For example, the ones in the eyelids are very common in very late stages of the disease where patients may have cognitive impairment, and usually there's no problem performing those. And in fact, this is kind of anecdotal, but for a patient that has some cognitive impairment or dementia, the treatment of these conditions, for example, making sure that they can be with their eyes open when they want, helps a lot because they can see things, they can communicate better. So it's not a contraindication. And if anything, I would pay more attention in those patients that may have needs that they are not able to communicate properly in order to try to recognize them and treat them.
Excellent. Do we have any other questions here before we say goodbye to Veronica and thank her for presenting today?
It
doesn't look like it, but that's excellent. Thank you so much for coming out and presenting. That was such an excellent presentation, and hopefully you can find some people interested in participating in your research. That's really cool. And I'll pull the information as well and see if it's not already up on our website, if we can get it up there and help sort of promote some of that to get some participants in there.
Okay, sounds good. Thank you very much
for coming out, and thanks everybody else for coming out as well. And this will be up on our website later today or early tomorrow morning. So take care and have a wonderful rest of your day.
Thank you.